Thank you. So congratulations, Simon. An excellent study, even though you rightly point out some limitations of the UK that tends to score well on league tables of palliative and end-of-life care, but clearly getting it quite badly wrong in some areas. So I'm assuming that most of your data, or virtually all of it, was collected in NHS, so publicly funded hospitals. There are 3 points I'd like to make, which perhaps broadens it a little bit beyond the UK. So you may be aware of Mary Niven's work from the Republic of Ireland, and she looked in her PhD work particularly about non-specialist palliative care providers in Ireland. And that may be something that was useful for you to look at and some of the work that they're doing there. You mentioned, so that's my point number one. Point number two is you mentioned that you were thinking of repeating this in care homes, nursing homes, or sometimes they're called long-term care facilities. And there was a really large European Commission funded study called PACE, which is Palliative Care for Older People. And it involved 7 European countries in a trial. But before the trial, what we did was a kind of audit, rather similar to yours, where we looked at samples of nursing homes or care homes across a number of European countries, in this case, 6 European countries, but with large samples. And the data are published. They're incredibly similar to yours. And mostly we sent an evaluator into each of the care homes. So this was not done just on a case note review or anything. So it was going in, collecting data from different sources, but actually physically going into the nursing homes. And interestingly, there were kind of 2 groups from the managers' perspectives. They either said nobody in the care home was dying because all of them were not at that stage moribund, or they said everybody's dying because all older people were considered to be in the process of long-term dying. Now, the average life expectancy in the UK in a care home is around about 2 years. So there was a real divergence in views, but the notion of recognizing dying was hugely problematic. And I think you've highlighted something really important there. And certainly in our data from that study, we showed that actually they were very, very poor at recognizing dying. There was, after an intervention, because we followed that up with a cluster randomized control trial, and we were able to demonstrate after a very intensive 6 months intervention that there was no evidence of benefit for the patients on their data, but there was a benefit in terms of knowledge from care home staff. So we increased the awareness and knowledge of end-of-life care in staff from that. My final sort of point, and you may know about this research, the King's College in London, very large hospital and an important university, in their Department of Nursing, they have been for a number of years looking at researching care not done. So when hospitals get very busy and there is pressure on nursing staff, which there is in many countries, and that has got worse through the pandemic or through austerity times when there's a lot of cuts in staffing. Things are not done, like mouth care, and you really demonstrate that. And one of the interesting things when they looked at very large data sets from UK NHS hospitals is that they found that there was less care not done in terms of having highly qualified nurses. So if you had degree level or well-qualified senior nurses, compared to just putting in lots of very cheap but unqualified nursing assistants or care assistants. So just people on the ground do not make the difference. It's the level of education and training that appears to make the difference. Now, this study wasn't particularly about end of life care, but since about 1/3 of people we know from David Clark's work in NHS hospitals are approaching the end of life, it may be something that is relevant. So those are the points, and you might want to come back and reflect on those. But thank you for your work.
Oh, gosh, thank you so much. There's so much to think about, and I'm picking that. And I've made a note of some of the names that you spoke of, because I wasn't aware of Mary Niven's work in Northern Ireland, so I'll certainly follow up with that. I think the points you speak to about the recognition of dying in the care sector are very familiar, and I think you're right. And actually, the points that those care managers and nurses were making, actually, what is dying? You know, is it the sort of the slow dying, or is it the last days, or what classifies that? I think they're very valid, and I think that the conversation we need to have is probably a little bit more nuanced than just the word dying. It's probably, as you sort of allude to, it's actually, are they dying in the next 3 days? Are they dying in the next weeks? Are they dying in the next months? Are they dying in the next years? And each group is dying, but perhaps requires a slightly different response. And certainly when we're looking at moving this work into the care sector, we'll have to adapt it, because we'll probably want to capture those that are in, say, the last year of their life and how their care is shaped, rather than just simply those that are in the last hours today.